And I think there are a lot of misconceptions about what actually we can spend on to improve health, and some of the things we're not spending on that probably would do a better job for us in terms of improving health outcomes. So that's what I'll be walking through here over the next few minutes. Until recently, I think efforts to improve the health of Americans has focused primarily on coverage issues. The Affordable Care Act was focused on getting more people access to insurance coverage. And in fact, today we have the lowest uninsured rate in our country's history. So that worked. However, on the spending side, costs continued to climb, and it doesn't always translate into improved health outcomes. So that issue of we're spending more, but we're still sick. What is it that we can spend on to improve our health outcomes? So you've seen versions of this picture. Per person, we spend more on health than any other country, and quite a bit more. That's the red line that's racing from the left to the right. And our health outcomes are not good. In this case, the vertical measure is life expectancy, and ours is lower than other high-income countries. So many policymakers and researchers support the position that high U.S. healthcare spending is the result of underinvestment in social services. This feels right because low social spending is associated with poor health outcomes. And the ratio of U.S. social spending to healthcare spending is very low compared to other countries. But it turns out the ratio is low not because social spending is low compared to others, but because that healthcare number is so high. This may surprise you, but the actual amount of social spending in the U.S. is in line with other high-income countries. It only looks low compared to health spending. So here you can see that same high healthcare spending, this time as a percentage of GDP, and the U.S. is clearly higher than other countries. But left to right, the measure is social spending, also as a percentage of GDP, and the U.S. is slightly above the average for high-income countries. That's interesting. We don't spend less on social programs. The same is true on a per-person basis. That's probably not the conclusion you were expecting in a presentation on social determinants of health. But it leads to an important insight. How we spend, if we really want results, is as important as what we spend. Before spending more on the same ideas that have not produced the outcomes we want, we should ask a few basic questions. So what actually determines health outcomes? Clearly, social conditions are important, and don't worry, here in a second I'm going to say it's the most important thing we can do related to health. But what social spending has the biggest impact? Are we talking about the health of a whole population or the health of individuals? And how can we target what we spend to achieve the greatest impact? On that first question, here's an account of what actually determines health outcomes. It's not a new idea. This allocation has been around for about 20 years. What jumps out is that most health is not determined by clinical medicine. Your health is determined before you see a doctor. Genes and biology are important. You can't change those. And for some individuals, that is the most critical determinant. But in general, our health status is determined by social conditions related to our physical environment, health behaviors, and social and economic conditions that create disadvantages or opportunities for healthy living. The World Health Organization gives us this definition, and for most of you, I think this is what you would say the social determinants are. The social determinants of health are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, resources at global, national, and local levels. Now, in another presentation, we should look at health disparities between high-income countries and low-income countries. It's shocking. But today, let's focus on the impact in our local communities. So the social determinants of health are mostly responsible for health inequities. These are the unfair and avoidable differences in health status seen within and between countries, and for today we'll say among our communities. That's an important phrase, avoidable differences, because it means that by reallocating the distribution of money, power, and resources, we should be able to reduce unfair differences in health outcomes. So, at a basic level, we all feel these social determinants. One neighborhood may have a strong sense of community, a thriving economy, good food, safe places for recreation, good schools. Here, the physical environment makes healthy choices easier, and social and economic conditions reinforce healthy behaviors. In another community, individuals may be isolated, the economy on the ropes, risks to personal safety, struggling schools. Here, there are barriers to healthy living where the physical environment creates risks, and the social and economic conditions are something to overcome. Again, at a basic level, we get this, but it may surprise you how profound the impact is on health outcomes. So where you live influences how long you live. If you live in Stowe, up in Northeast Ohio, you can expect to live until almost 90. But in Franklinton, just a few miles from here, your life expectancy is 60 years. Think of that range. A difference of almost 30 years of life based on where you live. The same is true closer to home. This map shows communities within a few miles of where we are right now. Life expectancy in Grandview is almost 85. And at the Hilltop, it's about 65. Bexley, 85. The Near East, 67. So again, think of that, a difference of 20 years of life in communities that are less than 1 mile away from each other. Grandview is a community of opportunity. Franklinton lacks those opportunities. And the consequence of that inequality, in this case, is a matter of life and death. So let's take a closer look at how those social determinants drive these results and the disparities. So social determinants of health may impact any downstream health outcome, right? Heart disease, cancer, injury, stroke, diabetes, pneumonia, kidney disease. These happen to be the top 10 causes of death in Ohio. They also drive the 3 lethal epidemics that reduced US life expectancy 3 years in a row. Now, this year, just recently, we got news that it ticked up slightly, but for 3 years in a row, suicide, drug overdose, and alcoholism led to a decrease in US life expectancy. And disparities in infant mortality are one of the most tragic examples of how social determinants drive unfair differences in health status across populations. So this is always the point, and this is the point in my previous work, 8 years with the state trying to coordinate resources to address these issues. This is where you become overwhelmed, because the thought of making progress not only on one of these, but on multiple topics across the board, which is what you have to do to have any impact on life expectancy, is overwhelming. So what I'd like to do is put this in a framework that starts to create an approach that it makes it a little more manageable to take on these issues. So here's the framework. And the de Beaumont Foundation with the National Academy of State Health Policy and others put this together. It's a metaphor I think everybody's probably familiar with, that downstream, what happens, we're reacting, right? We have these downstream consequences where we're intervening at an individual level to treat medical conditions because something upstream went wrong. So this is a specific patient, and we're focused on the crisis. That's where our medical spend is. So double other countries, it's because we put a whole lot of money there. But if you can get into this middle level, And honestly, I think this is where most of the actual activity in social determinants occurs. And I would tell you this level is not social determinants of health. This is the identification of a social need because something broke down for a person, they're in the emergency department, but what they need is transportation or they have unsafe housing. So if you provide that, it saves health spending and improves health by intervening on the social need. But you're doing it at an individual level and it focuses on deficits. What is this person lacking that we can supply? Versus social determinants of health, which is an opportunity to improve the community and the conditions for everyone. You do this through laws, policy, regulation. It's the whole population, and you focus on assets. What are the assets in the community that contribute to health to avoid downstream consequences? So that's the framework. Now, back to the list I just described where we have infant mortality, we have suicide, we have drug overdose. If you think of those in this context, it starts to give you a way to approach the issue. So suicide deaths increased 45% in 10 years in Ohio. Was everybody aware of that? Suicide deaths are up 45%. It's a national trend. Look at this, youth age 10 to 24, 64% increase in suicide, right? So clearly an urgent issue here to address. How do you start to respond to this? Well, at the crisis level, you have case management for individuals with high risk. You have crisis intervention and treatment. But there you're just reacting to what's presented itself as a critical concern. What about gun locks and safe storage? 51% of suicides in Ohio are through firearms. So what are we doing in a household that has guns to make sure they're stored properly, they're safe? Standardized screening and referral. What if at the primary care level you encounter somebody showing signs of behavioral health care needs? Is there something to catch it right there and get the proper referral before it becomes a crisis? Trauma-informed health care. So again, these are addressing something you've identified as a gap for an individual, but before that, look at the first one. Raising the minimum wage correlates to a 3.5% to 6% reduction of suicide rates on average. Now this was interesting. This was a large study across many states looking at actual changes, $1 changes in the minimum wage and how it correlated to a reduction in suicide. Now, clearly, many factors are in play there. However, there is something there about the economy that is related to a person's condition and reaction in that situation. So school-based awareness and education, again here, doing more in schools so the general population is aware, so then it empowers individuals to act. Okay, I'm going to run through the examples quickly, but you get the point. Down here, we're really too late. Up here, we can create incentives. For example, managed care plans should just provide these things because if they do that, they're going to spend less on health care, they make money, and people are better off. So these are interventions, more localized, and then policy at the top. Drug overdoses in Ohio. So our overdose rate is twice the national average. Again, were folks generally aware of that? This one's gotten a lot of attention recently. A lot of reasons for that. We're at a crossroads of product being transported through the country. And the conditions here, particularly in some certain communities that are attached to what have been called deaths of despair, are very prominent in Ohio. So for whatever reason, Ohio is double the national rate, and that's about 5,000 deaths. Now, those of you who are following this, this is a separate presentation, but in this past year, we had a 22% reduction in overdose deaths. So that shows that when you bring real focus to these issues, and not a silver bullet focus, but across all fronts, you can really make a difference. So some of what's on this list is an example of things that I think have contributed to that most recent decline. So again, downstream, you're just reacting. You're getting people connected to medication-assisted treatment. You need access to providers. Because there wasn't really financing for behavioral health, there was a lack of providers. Recently, the Medicaid expansion injected $1 billion into Ohio's economy spent solely on behavioral health and addiction treatment, right? So without those funds, we had a lack of providers. With that financing, we're starting to build a provider base. Narcan, the life-saving drug, now present for free through pharmacies. Families with family members at risk can keep this at home. Emergency responders carry this with them. And that item alone, I think, has done more to contribute to that 22% reduction in overdose death. It doesn't solve the problem of addiction, but it does start to address the issue of overdose deaths. But really, community awareness and education, cutting off illegal supply, prescriber guidelines. Ohio implemented prescriber guidelines, and within 18 months, we had reduced prescribed opioids 30% in the state of Ohio. So these are regulatory and law-based interventions that can have a real impact on health. Okay, drug overdose. Now, these are interesting because these two examples, I mentioned the deaths of despair. They get a lot of attention. Honestly, I think they get attention because they're in mainstream areas. They're in communities that are in tune with this. But it doesn't get at where what I would call real disparities exist, disparities across communities. And this is the best example I can think of that. So here is infant mortality in Ohio. And it looks like good news, right? Because this past year was the second lowest infant mortality on record, and the lowest year was just a couple years before that. And if you trace this back, this trend has been steadily declining for a century. But if you add in a little bit of detail, the blue line is white infant death, and the red line is black infant death. The number of black infant deaths has been on the rise, and the rate is triple what it is for white children. So here's an example that there is a glaring disparity that can get lost in the aggregate data, but if you look community by community, you can really isolate where in some areas, in Dublin, probably not a lot of need for services to address infant mortality. In other parts of the city, a really dire need to address some of these issues. So what some of those look like: intensive care for high risk. One thing we did recently, again, with Medicaid managed care plans, which cover half of all births in the state of Ohio, in any zip code with high infant mortality, the managed care plans are required to use the highest level of care coordination for everybody who lives in that zip code, and then only step down from that if they can show it's not necessary. So instead of looking for somebody at risk and then providing care coordination, you provide intensive care coordination for everyone until you can show it's not needed. But again, you're intervening when it's too late. So then above that, smoking cessation. A lot of Ohioans smoke, directly correlated to low infant birth weight. Services to support healthy birth spacing. For women who have a child, low infant weight is related to the time that passes from the first birth to the second. And if you can stretch that time out, the chances of that second birth being at a higher weight goes up. Community health worker referrals. So again, intervening with social needs of individuals, but then up here, comprehensive primary care. Now, back to this theme. So how we spend is as important as how much. And I've been talking about these kind of embedded in each example, but set clear priorities for existing resources. An example there, when 8 years ago, as the drug overdose epidemic was kind of taking off, the immediate response was to spend a whole lot of money, and billions of dollars have come from the federal government. But one of the things we did in the state was inventory the resources we already had, and we already had $1 billion at our disposal that was being spent on that issue. It's just that it was being spent this way, and we needed to do this to get it coordinated in a way to get more value for the money. So again, back to that original point, that it's not necessarily how much we spend, but how we spend is important. Surging resources to the greatest need. I mentioned Dublin doesn't not need a lot of help on infant mortality. The Hilltop does. So how do you move resources to where the need is, and then tie financial incentives to social priorities? Right now, providers get paid for people who are sick. They do not get paid for people who are well. We need to turn that on its head, so the financial incentive is to reward health outcomes. But again, that's probably big enough for another presentation. Cross-cutting outcomes. I mentioned primary care, but there are a lot of them. Early childhood supports, school-based health, affordable housing, employment and income, comprehensive primary care. Investments in these areas improve measures across the board. So again, a way to focus. Incorporate health in all policies. So this is the idea that often the health discussion is a public health question, or maybe the financing, for example, what does Medicaid do to improve health? But really, what is the neighborhood like? Do folks have access to good education and health supports where they receive their education? What is your environmental policy, energy policy, humans? Across the board, there are chances to make gains with health outcomes in all of these sectors. So at what level of government are you pulling it together? At what level of this university are you pulling it together to create a comprehensive view of an approach? Okay. There is a lot of great information on this topic, and here we're leading into the discussion part, which is what I'm actually looking forward to the most. The state of the Ohio Department of Health has recently gone through several iterations of an improved state health improvement plan that calls out much of what I just described. Behavioral health and addiction, infant mortality, chronic conditions, and strategies, including cross-cutting strategies for all of those. So if you're interested in this area and want a starting point of a complete map of the landscape, I'd encourage you to start there. The Health Policy Institute of Ohio provided a lot of leadership to the state in developing that plan, and through them, they have a number of additional resources in this space. The de Beaumont Foundation is the organization from the river, the upstream picture. They have a lot more than just that picture. So that's a good resource, and I mentioned the National Academy for State Health Policy, all of which is available to you to get to the next level in this. And by the way, at this point, I'd also say another way to get to the next level are the next 3 or 4 lectures that are coming up. Because where this is kind of a very high-level overview of maybe how to think about it, really the on-the-ground work to intervene and address these issues, that's where the real excitement is. And I think over the next couple lectures, that's a little bit of what you're going to hear. Okay, it's a lot of information all at once. I did that on purpose so we can kind of expand the space where we can talk about this. I'm glad if there's a picture that relates to something you want to talk about, let me know and I'll run back and I'll put it up so we can discuss it. Okay, questions? Yeah.
I'm wondering, in the picture of the map of Ohio where you have the differences in the life expectancies, I was wondering if you could explain either how that is calculated or to what extent that is driven by infant mortality.
Yeah, so the National Center for Health Statistics runs this down to a census tract level. And I couldn't tell you all of the sources they draw from to calculate the life expectancy, but that's the source of the calculation. What's great about it is there's a spreadsheet that lets you create this picture however you choose using that data. So I can't answer in detail the source, but for me, that was the source of this. Can be, and it could be different for different communities. However, I would say that across the board in a low opportunity community, that first list of issues I listed, cancer, diabetes, things that are driving mortality, the numbers in those categories are so large that disparities there also really drive that difference. The infant mortality piece, I think, is the easiest one to spot and to zero in on. The numbers of actual mortality are lower, but I would never say that makes it more or less of an issue than the other categories. So, but I think in general, what you'll find is social determinants where there are disadvantages in a community, they play themselves out across many of the health measures we look at. Yeah. And by the way, I would say, I should have said this at the beginning, there are a lot of friends in the room who I know a lot more about this than I do. So Dr. Long, others who are here, feel free to get my attention if you want to jump in.
You did a nice explanation. It's kind of a complicated calculation, but it is now becoming more and more available. The Kirwan Institute has Ohio's and all of our, I don't know about census tract, but zip code numbers for life expectancy, but you're on it. If you have a high infant mortality rate in your zip code, you will be losing more people early on. That drives down your life expectancy for that area. But just as Greg said, you also may have in that same area a lot more of these chronic conditions, and people are likely dying earlier because of them, and the deaths of despair. So it's really multifactorial.
It's that example you probably all had in history class where, wait a second, life expectancy was 45, but Benjamin Franklin was 80. How does that compute? And in fact,
We can't all expect to be Franklin.
We can't expect to be Franklin, but many people died very young, which significantly lowered that mortality rate, even though that if you survive beyond age 5, mortality was not as good as it is today, but it looked more like what we would expect, right? And it's that dynamic embedded here. Yeah.
Greg, would you have anything, I'm thinking a comparative perspective, right? I could imagine when you say social determinants that some of these social determinants have to do with the degree of inequality, unequal access to education, to health, to decent stores, to stores with decent food. Would you say that I find these differences that you show on the map here in terms of life expectancy quite stark? Say in countries where there is more access to health insurance, not necessarily universal health insurance, but northwestern Europe. Are those differences, despite the fact there are inequities in all countries, as far as I know, are those life expectancy gaps less than they are here in the United States? Yeah.
So here I'll attempt a beginning, and please, anybody is welcome to join in. The cluster of life expectancy across those countries is tighter because it's above 80, below 84 for most of what we would consider high-income countries. So the variation is less there. The health spend is also more concentrated. So from left to right there's a pretty big range, but it's still fairly concentrated, and then we're the outlier. One of the interesting things looking at health spending, which is a lot of what I've done, is when you look at the things that you think would make us look different than those other countries, we utilize more, we spend on more high-cost things. Most of that is not true. We actually utilize primary care at similar rates as those other countries. And we don't overutilize high-cost things that much more compared to those countries. The differential is price. We have a price differential compared to those other countries. So I would argue one version of this is we just have a price problem that if you reset, we actually don't look that different from those other countries. Now, on the social spend side, I think the real interesting question is, okay, so here's the aggregate. Left to right is the aggregate as a percentage of GDP. But for a country here that if you look back on the other chart and see they have a really high life expectancy, do they have some magic combination of social spending that is better than our combination of social spending? And that's where they're getting results. So this analysis doesn't get to that level. I think some of the things I was pointing out, where we spend money, including, for example, a foster care intervention for a family where the parent can't care for the children because they're addicted, we count that as social spending. But if we had spent that money earlier and avoided it, think about that, our social spending would have been lower and we could have gotten a better result. So the question is, and I'm not saying don't spend money on foster care, because we're here you have to, but can you push some of that spending into space that is improving health outcomes and avoiding the unnecessary high cost? That's the question I think to look at compared to other countries to try to gain the insight. Does that make sense? Yeah.
You said Ohio is spending divergently on the same project instead of concentrating. Is that study available? Is there any, where can I find the numbers on that?
That is a well-formed opinion of mine from being responsible for going from this to this. But I will give you an example because there are examples everywhere, right? There are examples everywhere. So a few years ago, there was a requirement that every community do community health needs assessments. Every health district had to do one, and every hospital had to do one. If you add up health districts and hospitals, there were more than 350 of those community health assessments. And everybody was acting on what they found with their own plans. That's this. A few years ago, we moved to a system where every 3 years, at least at a county level, the health districts have to plan together in cooperation with the hospitals. In many communities, they're now generating one community health assessment, and then the plans are based on that kind of one view of the truth. It's more efficient, but really the power of that is, at a community level, you can see what to work on together. So that's a very specific example of how that makes no sense, and if you can get focused together, it really can make a difference. And we could play a game where you name a topic and I'd describe how it works that way. And we could hit just about every area of spending in the state. Yeah, so for example, it used to be that a lot of the money that states use to act on this issue comes from the federal government. It comes in the form of a grant. The state very fairly then parses that out across the state in a way that every community gets its fair share. But we just saw not every community has the same level of need. So can you target that and can you consolidate those funds and surge them into a community where they stand to do more good? That's an example. I mentioned the managed care plans. The managed care plans don't do intensive care coordination until somebody hits them in a way that they're like, whoa, they're expensive, we're gonna do intensive care coordination. Well, by then it's too late, and especially with women who are maybe pregnant and at risk of having a low weight birth. Why not turn it on its head and say, look, if you live in an area, managed care plan by definition, you have to start out with intensive care coordination and then step it down later if it's not necessary. So again, that's an example of where the plans were all doing something different. That single focused policy brought everybody onto the same page. Yeah.
On one of the second slide, maybe your third slide, where you talked about social determinants of health, one of the factors that you had listed was power. And I was wondering if you could just speak to what that means in this context.
Yeah, I think this is great that the World Health Organization calls it out this way. And if you think about it in a global context, we're not talking about variation here, we're talking about variation here. But it's really about control of resources, right? I mean, I was an economics undergrad, but my master's was in philosophy. And I always took that combination as the perfect combination in this space, right? It's the just allocation of scarce resources. That's really what healthcare is about. And justice is determined by issues related to money, power, and resources. The amount you have to allocate is related to money, power, and resources, right? And that next picture that shows two communities, you don't have to think too hard to see a disparity in power dynamic of money, power, and resources between communities just a couple miles apart here in central Ohio, right? So I think pretending it's not that will never let you get at the real issues of what you need to do to reallocate resources to get it in the right place. Does that make sense? Yes. Yeah.
So thank you very much. We haven't met yet. I'm Amy Fairchild.
Oh, you're top of my list. I'm so glad to see you here.
This gave me an aha moment because one of the things that we struggle with in public health sometimes is that anything before you get to the clinical setting gets labeled a social determinant of health. So this is brilliant, and this helps give me the language to help folks parse that out and push their thinking farther upstream and help them understand where public health tends to sit, and really thinking about the social determinants and the way they lie at the top of your picture. The thing I wanted to ask you about, though, is in a number of your slides you had community awareness and education in that the true social determinants section. And as I've been going through my head, depending on how we describe education, I can imagine some educational initiatives, maybe anti-stigma initiatives that really prevent discrimination as truly addressing the social determinants. But one of the things I'm always skeptical about is we invest heavily in public health and educational initiatives that I think maybe feel good, but don't have a lot of impact. So that seems to me that's one that either falls off. So how are you thinking about, when you say education, how are you thinking about education as a social determinant?
So I'm so glad you brought up that specific detail, because if we were having a proper conversation on every one of these, we would insist on talking about evidence-based interventions. And there are a lot of interventions that, as you describe, I think feel good. We used to call it, and I'm sorry for the Department of Health folks here, Department of Health billboards, where folks love putting up billboards about doing something, this or that, related to smoking cessation. Maybe they had an impact. I largely believe probably they had no impact at all. But I'm not sure we knew, because we didn't systematically evaluate it either to know if we should do it again or not. Now, what's great, and pointing back to both the Department of Health and the Health Policy Institute, there's a growing base of evidence on how certain interventions work in this space. And increasingly, things like the State Health Improvement Plan require folks to select from a menu of evidence-based interventions. So for example, awareness through school-based programs that are tied to evidence maybe can have a specific impact. If it's a general approach, maybe or maybe not. So it's not a specific answer. We'd go back down through every one and say, well, what about this, what about this, what about this? But I think for a community like this, it creates a real responsibility too to ask the question, well, do you have any evidence that that intervention worked? Because remember, my whole premise from the beginning was, we already spend about the same as these other countries. Are we spending on the right thing? So one interesting question would be, do other countries spend more on evidence-based interventions and we don't make that a priority? Well, that could be one of those things separating us. The one thing that bugs me the most is I do think a lot is collapsing into this space here. And it's a simple reason. It's who's got the money, right? Who's got the money? So right now, a hospital system, a managed care plan, where all the money is, they're overspending on things that could be avoided. So that idea, if you're a managed care plan, you get the same amount of money for this person, they keep hitting the emergency department, but if I could get them transport to primary care on a reliable basis and avoid those ED visits, I save money. That's a good incentive. because it's also better for the individual. But that's not about social determinants. That's generating a return on investment for an entity that's operating in the social needs space, and they see an opportunity to make money. Now, I would argue we should turn the whole system on its head, so everybody's financial incentive is to seek out those things further upstream that actually keep people healthy, but we are a very, very long way from that result. So most of what we do is Band-Aids. It's triage in this level, or it's Band-Aids in this level, and in a few really notable cases, like a smoking ban in public spaces, we make huge leaps forward in those upstream changes that affect downstream health. Yeah.
Great transition, because I've spent most of my career writing language for smoking bans in public places.
Yeah. Uh-oh.
I mean, all of these things on your list, I mean, I think you said that very well. Like, this is a great way of kind of forcing people's thinking upstream, but you want the evidence of what actually works. And you also, all of these things you can do in better or worse ways in terms of actually structuring the policy and how it gets implemented and enforced and communicated and so on. So you asked the question, how are we coordinating across campus to take everyone's different sorts of skills and put them together, and my sense is we have a lot of room for improvement there. So I don't know if you feel comfortable having been on campus long enough, but what would be your ideal vision of how we could better coordinate across Ohio State to use the expertise we all have?
I'm new enough to know not to answer that question. No, actually, my first experience, I was here before I was with the Kasich administration. I was the chief of staff for Bernadine Healy, who was at the College of Medicine. And at the time, the dean's vision was that, look, public health is over here and underfunded. The College of Medicine is over here with all the money. The future is going to bring those things together. And my job was to run the accreditation team to look at a College of Medicine and Public Health. Now, as you would expect, the accreditors would have none of it. So we accredited a separate College of Public Health, not a combined college. The concern was, I think, from public health, medicine always gobbles up everything and they'll gobble us up too. And I think that's a fair criticism. However, I do think Dean Healy was about 20 years ahead of the curve in predicting that the future would all be about trying to get a handle on social determinants to avoid unnecessary health spending. So my lesson about the university structure in that case was that it shut all that down. So I think the issue now is times have changed. I think folks come at this differently. I think there are natural alliances among nursing, public health, public affairs. I think there are, I would say just about everything, agriculture, we could keep going. And there's a new financial reality in this space where the provider side has to compete. Not yet, but we can see a point where maybe they have to compete on keeping people well. Does that open a door back at the medical center again to have that conversation? That'll be interesting where that goes over the next couple of years. And I'm hoping actually half a dozen people in this room are probably going to be a part of that. Yeah.
Another question, Greg. When so much money is spent on downstream consequences, can it be argued that that is in part a function of the fact that a lot of healthcare spending is driven by interest groups who have property interests, say the pharmaceutical industry? They have no interest in community impact policies because they don't make money.
Yeah.
Now that's very simplistic, I realize that, but I would think some regulation, but that relates to what you said earlier about pricing, right?
Yeah. Yeah, I think that's the key. So I think if I were a lobbyist, I'd be in the legislature saying, are you kidding me? These are all problems. And the solution is we need to get rates higher so we have the right kind of providers in our state to address these issues. And in fact, a lot of this discussion gets translated into the thing we pay for now, which is provider rates. And Ohio's different than other states. our hospitals are paid 24% more on average than hospitals nationwide. That's an interesting detail. Back to this issue of community level planning, to maintain their nonprofit status, hospitals have to take a portion of their money and take it away from them into the community to invest in things that have community benefit. That's the deal. If you want to not pay taxes, you got to spend in the community. Most hospitals spend things on themselves. It's Medicaid bad debt, it's things that cost the hospital that they claim as a community benefit, but it really isn't. So why not require them to spend that money in the community? Well, there's an example where you're starting to reallocate those resources from kind of where it's currently consolidated to where it could have more impact. And again, one tiny example, we could churn out a number of examples. Other questions? Yeah.
About the strategies in the community impact upstream. So many times post-work evaluations focusing on where the populations are, because that is where you can see the improvements and effectiveness. But since improved community conditions will have different phases. For example, in the urban settings where a lot of populations are, you intervene and you have the social determinants of health interventions, you see the results. But in many of the places, in the very remote rural places, like each of the houses are 5 miles away from each other, there is no such a community sense. It's really hard to implement anything. So I would like to hear from you about the over-urbanization type of thing where you focus mainly where the populations are, where the problems are. I want to hear about this.
Yeah, no, absolutely. And again, especially if you're driven something like mortality rates and bringing those down, mortality occurs where people live concentrated in urban centers. So what you're saying is exactly right. The attention tends to go there. Now, I would say even at that level, to really grasp this, you have to get really far back. So for example, in an urban center, deciding that a highway doesn't split the community down the middle, creating one community of low opportunity and another community of high opportunity, versus the way it was before where some of that opportunity could flow where the highway now sits. Those are the kinds of examples that you have to get that high a level to really imagine what a community impact could look like, right? What I would encourage you to think about though is what are the challenges that what creates an opportunity for healthy living and what creates a disadvantage. In many rural areas, you have more opportunities for healthy living. Maybe you walk more, there are opportunities for recreation. There are states that are big examples of this. Colorado is really healthy. Maine is really healthy. And it's largely related to the physical environment. So I wouldn't discount that. So it's pros and cons. Now the challenges are different, but they're still there. Maybe it's transportation infrastructure. Folks just aren't able to get to care. What are solutions like telemedicine or telehealth that can overcome distance in a way if it's still appropriate for whatever the intervention is? It draws attention to deficits that then you can fill. But again, a lot of it's happening in this space because it's easy to put your finger on the deficit. It is harder at that broader level because probably less resources, maybe less organization to be able to intervene at the higher level. I think the state is a great level of intervention at this top level because you can have a smoking ban statewide. You can have a telehealth policy that increases access throughout the entire state. So basically overcome some of the scale issues in small communities by using the policy of the state.
Yeah. First of all, that was a tremendous presentation, full of genuine insights, and I agree with Amy. It was a really terrific focus.
And not too much criticism of the medical center, I hope.
Not too much.
Okay.
I have a question for you. I don't know if you know the answer, but I was struck, like everybody in the room, by the breadth of differences in lifespan and variations. We used to look at variations in costs, small area variations. but I was really struck, I don't know if you want to go back to the map. And then the graph that you have on lifespan against expenditures, but really focusing on lifespan. Do you know at an international level in developed countries, is there the concentration like that in census tracts like there is in the U.S., that is, these disparities, or is it more, are the differences in disparities also different?
Using the social determinant definition, it would lead me to assume yes, and depending on the environment, more or less. But I don't know. And I haven't seen the level of kind of that census level data for other countries. It's not something I've looked at.
Well, and I wondered if you go back to the graph that plotted with all the other developed countries, which is striking. I don't know, maybe it's a scale. I don't know where it is now.
This one?
No, there it is.
Yeah.
There it is. And I'd always been struck by that in terms of cost, because tracking as recently as in the 80s, the differences were not as stark in terms of the costs per individual. And then in the 80s we took off, but the lifespan differences also flattened out. And I wondered if it was there was anything to do with the way our cities and metropolitan areas began to develop with massive suburbs and concentration of wealth in metropolitan areas.
And I don't know about that, but you zeroed in on what I think is one of the most interesting details of this picture. Here, we're spending roughly the same as other countries. Think of this. At the point we started spending more on healthcare, our results got worse compared to everybody else. That's one way to interpret this. So, short of going to other potential causes, which I'm sure are out there, I'd be curious in this correlation between what happened when we started spending more that caused our health outcomes to flatten out. And so, for example, I can think of some obvious examples. If pharmaceutical companies invest huge amounts of money in training doctors to overprescribe, and that becomes the norm, so the spending on that product goes up and it kills people, well, there's an example where additional health spending is actually decreasing life expectancy. Now, I'm pointing that out as kind of a rare point, I hope. However, duplication is not good. Having providers who don't necessarily know what you're being prescribed and potentially creating harmful interactions. Hopefully our systems are getting better and better and better to the point that is not a part of the system anymore. But those are all examples of where additional health spending actually could be killing us, right? So you really have to sort that out. Ned.
Okay, so I'm looking at this chart in particular. You mentioned that a big difference on the red line is just pure price inflation.
Not the total difference, but a significant chunk.
It probably would be helpful if you could actually take a standardized measure of price and factor that, so you had a U.S. line which is saying if we pay comparable rates, so you kind of get price out of it, and then you could also look at the other incentives.
Somebody's dissertation. Ned just put on the table. Yeah, no, that would be really interesting to look at. And again, it's really complicated because, for example, our utilization of non-primary care has dropped significantly. It's actually been negative.
Right.
But the costs in that setting are higher than they've ever been because that gained efficiency has been more than offset by the increase in price. So depending on the setting you're looking at too, there are different stories about what's going on. And we're really close on time. I respect that, most of you plan for an hour, but I'll go all day. So next question.
I'm going to kind of take it back to community specifics and social determinants. And looking at, you mentioned the evidence-based interventions and then the databases that have been developed. And working in urban spaces, especially if you look at our, life expectancy, and we work in a lot of, so I work for the Wexner Medical Center and the James Center for Cancer Health Equity, and we work specifically in a lot of these communities that have very low life expectancy and high lack of social determinants. And what I find difficult is that the evidence-based interventions are not based in those communities or other underserved communities. So I work specifically with the LGBTQ community, which, and then you add people of color to that, and finding interventions that are even present are non-existent. And so as an academic facility, how do we incentivize not only like us, but other individuals in our spaces to then start putting money into those spaces so that we do have the evidence-based interventions to then facilitate some change in these communities?
Yeah. And, to go back to an example I gave earlier, Bernadine Healy, the National Institutes of Health only did research on men and then took the results and assumed it kind of worked the same for women and kids. And Dr. Healy was like, that doesn't make any sense at all. So initiated the Women's Health Initiative through the NIH, which actually showed these are pretty big, different results. She was called in front of multiple congressional committees for her distracting resources away from the core mission of the NIH. That's about power, right? It's about money, power, and resources. And she had the clout and credibility to challenge the system and change it, right? What you're describing is the same thing repeating itself over and over and over, community by community. And again, it's why communities that are doing well, they can't afford to kind of throw resources at these issues if they need to. And if you don't have those resources, what do you do? I think it also ties to the special responsibility we have about where we choose to look, right? Because we can look where things are fine and get funded. It might be harder to look where things are not fine, but the insights there are going to have more impact. So exactly what you're doing is actually the answer to, right? So, and I know you know that, but what you're doing is the answer to that question. Not everybody's the same, and even the health things you're looking at are totally complicated in different ways based on those other social factors that are present around you. And so far, like a clinical trial is looking at one medical piece. It's not necessarily looking at those other factors. Okay, Dr. Long?
Good discussion for all of us. But this kind of example and money, power, and resources, it really takes us back to that river, right? And in this room or this university, there is a lot of power and resource, but it's really going to the policy level. It is going up to the community level. I'm in lots of conversations with people, a lot of physicians, and they are so excited about population health, but their definition of population health is that middle section that really is, we're going to look at the housing needs of this patient. We're going to look at their social needs, and then we're going to treat those conditions. And we have to collectively, somehow, maybe some of us in this room and others, but get to how do we address those policy issues that are really going to change it for everyone. Or otherwise, we're going to keep spending a lot of money at that middle and, of course, at the lower patient level.
So I mentioned at the beginning, I'm new here. And I've got to say the quality of this conversation is fantastic. And keeping the conversation going is important. So individually, I heard several things I want to follow up on. You have, like I mentioned, opportunities through this lecture series to get back together again. We should all do that and keep the conversation going. But I do think there is a unique opportunity in this space. It's the emerging area that's going to define what healthcare looks like over the next decade, and especially the financing piece if we can get it connected to these priorities. So anyway, that you're interested in this, I think your instinct is good because it's going to be really interesting for a while. So with that, I'm just going to say thank you. Thanks.